All right. Hey there, deep divers. So you're back for more, huh? That tells me one thing. You're the kind of person who really wants to get to the bottom of things. No skimming the surface. You want to understand the how and the why, especially when it comes to something as important as healthcare.
Couldn't agree more. And today we're going deep on something that's absolutely crucial to good healthcare: clinical reasoning. It's the thinking process behind every diagnosis, every treatment plan, every decision a doctor makes. And it's more complicated than you might think.
Way more complicated. In fact, the way we think about clinical reasoning and even how we assess it in doctors has changed a lot over the years.
Oh, absolutely. And the sources we've got for this deep dive really lay out that evolution in a fascinating way.
Yeah, we're looking at a mini review here that brings together a ton of research and different perspectives on assessing clinical reasoning. So, our mission today, well, we're going to extract the key takeaways from all of this so you don't have to wade through mountains of research papers. We're talking shortcuts to understanding this complex but really important topic.
Exactly. We'll uncover how clinical reasoning is evaluated, why it's so challenging to do well, and where the field is heading. Ready to dive in?
Let's do it. Take us back to the beginning. How did this whole journey of trying to assess clinical reasoning even get started?
Okay, so picture this. It's the 1960s, and there's this very practical need to figure out how to assess doctors in a way that actually reflects what they do in the real world.
Makes sense. You want to make sure doctors are ready for those real-life patient encounters.
Right. And that's where the patient management problem, or PMP, was born.
PMT. Got it. So what was that like?
It was essentially a simulated case, first done on paper and later on computers, where a doctor in training would get a patient's initial complaint and then work through the case, making decisions about what questions to ask, what exams to do, and which tests to order.
So kind of like those choose your own adventure books, but for medicine.
Yeah, in a way. The idea was to try to mirror the actual steps a doctor would take in real life, and it seemed pretty straightforward at first. Mimic reality, assess competence. Simple, right?
Sounds logical. So what happened? Why didn't it work out so well?
Well, as they started using PMPs more and more, three big challenges popped up, and they really threw a wrench in the works.
All right, lay them on me. What were these PMP pitfalls?
First, researchers started to realize just how individual and unique expert problem solving really is.
Meaning what exactly?
Okay, so imagine they get a bunch of top-notch doctors, real experts in their field, to score these PMPs. You'd think they'd all pretty much agree on the best way to handle a case, right?
Yeah, that seems reasonable. They're all at the top of their game.
Well, what they found was actually a surprising amount of disagreement. Not just on little details, but on big things, like what the optimal path through the case should be.
Wow, that's kind of a shocker. You'd think there'd be more of a consensus among experts.
Right, and this discovery really started to point to something called script theory.
Okay, script theory. Tell me more about that.
So the basic idea is that experienced doctors develop these very personalized illness scripts over time. It's based on their unique training, the specific cases they've seen, all of their knowledge and experience.
So it's like their own internal database of patient patterns.
Exactly. And these scripts help them quickly recognize patterns in a patient's symptoms and connect those patterns to potential diagnoses and solutions.
Yeah.
It's almost like an intuition or a gut feeling, like this feels like X. But because these scripts are so personal, so unique to each doctor, it's really hard for them to explain their reasoning in a standardized step-by-step way.
So their expertise, the very thing that makes them so good, is actually working against them in a standardized test setting.
Exactly. It's like asking a master chef to write down every single detail of their recipe. They just know what works. It's ingrained in their experience.
Okay, so expert idiosyncrasy, challenge number one. What was the next hurdle for PMPs?
Challenge number two was domain specificity.
Domain specificity, break that down for me.
Essentially, it means clinical reasoning isn't this general, transferable skill like basic math. It's really tied to specific knowledge within a particular area of medicine.
So a brilliant cardiologist might not necessarily be a whiz at, say, infectious diseases.
Exactly. They might be amazing at reasoning through a heart problem, but struggle with an infectious disease case, even though both are within internal medicine. And when they actually studied this, they found shockingly low correlations, like 0.1 to 0.2, between performance on different PMP cases.
Wow, that's a weak link. So to get a real picture of a doctor's reasoning across different areas, you'd need tons of these elaborate PMP simulations.
Right. And that brings us to the third big problem. Logistically, it would just be a nightmare. Imagine the time and resources needed to create and administer all those tests. Completely impractical.
Okay, so we've got these three big issues: experts thinking differently, reasoning being tied to specific areas, and the impracticality of testing everything. What else?
Well, there's one more really interesting wrinkle. They found that sometimes practicing physicians were actually outperformed on PMPs by, get this, medical students and junior doctors.
Wait, really? That seems totally backwards. You'd think experience would win out every time.
You'd think so, right? But here's the thing. Experienced doctors rely so heavily on those well-developed illness scripts, they often need less information to get to the right answer. They're efficient. PMPs, however, rewarded thoroughness. So those experts who quickly zeroed in on the key points and made a decision were sometimes penalized for not meticulously exploring every single avenue.
So being a sharp, efficient doctor actually worked against them in the PMP format. That's a pretty big design flaw.
It was a huge wake-up call for the whole field of medical assessment. They realized that just because an assessment looks authentic, like it mirrors real life, doesn't mean it's actually measuring what it's supposed to measure. In other words, it might not be valid. And this is a crucial lesson, especially these days with all the fancy VR simulations and stuff.
That's a great point. Just because something feels real doesn't mean it's an accurate test.
Right. So those early attempts to assess clinical reasoning with PMPs, they kind of hit a wall. It was time for a new approach.
All right, so let's talk about that shift in thinking. What came next?
So around the late 1980s and early 1990s, people started to move away from those long branching case simulations like PMPs.
Toward what? Exactly.
Two main alternatives emerged: the key feature approach and extended matching items. And both of these new methods focused on shorter, more targeted scenarios.
Okay, I'm intrigued. Tell me more about these streamlined approaches.
Sure. The key feature approach involves giving someone a brief patient scenario, like a paragraph or two, followed by a few very specific questions about crucial decision points. And these questions could be open-ended or multiple choice.
So instead of going through a whole case, step by step, you're zeroing in on the most important decisions.
Exactly. It's about efficiency. This way, you can test someone's reasoning on a much wider range of clinical problems in the same amount of time.
Makes sense. More bang for your buck, assessment-wise. And what about extended matching items? How do those work?
With extended matching items, you start by giving the test taker a list of possible answers. Could be diagnoses, treatments, whatever. Then you give them a bunch of short patient vignettes, and they have to match the best answer from the list to each vignette.
So kind of like a matching game, but with medical scenarios.
Exactly. And again, because the scenarios are short, you can cover a lot of ground quickly.
Okay, so these newer approaches sound more efficient and maybe more focused, but did they actually solve those earlier problems with PMPs?
Research suggests they did a much better job. They were better at dealing with domain specificity, the whole experts think differently thing, and even that intermediate effect where less experienced folks sometimes did better on PMPs.
So real progress was being made. They found better ways to assess how doctors make decisions. But the source material suggests that even these newer methods weren't quite capturing the whole picture of clinical reasoning.
You're right. They were good at assessing the end product, the decision itself, but they didn't really dig into the process, the thinking behind that decision. And that's a critical piece of the puzzle, right?
Yeah.
You want to understand how someone got to that answer, especially if it's the wrong answer.
Absolutely. So how did they tackle that? How did they try to get inside the doctor's head, so to speak?
Well, that's where the script concordance test comes in. This is a really interesting one.
Okay, tell me more. How does that work?
All right, so imagine a short clinical scenario, just a quick snapshot of a patient. You also get a proposed hypothesis, like, based on these symptoms, you're thinking it could be condition X. Then they throw in a new piece of information, like a lab result or something, and ask you, does this new finding make the hypothesis more or less likely?
Interesting. So it's not just about picking the right answer, but about how your thinking changes with new information.
Exactly. And here's the really cool part. The way they score this test actually takes into account that different experts might interpret the same information in slightly different ways based on their own experiences and those illness scripts we talked about earlier.
So they're acknowledging that there's not always one right answer, that expert reasoning can be a little bit subjective.
Right. And the scoring is based on the responses of a whole panel of experts. But there's kind of a paradox here, a tension that some people point out.
What's that?
Well, on the one hand, the test acknowledges that different experts might have different interpretations. But then it still scores you based on how closely your answer aligns with the average response of that expert panel.
So they're saying it's okay to think differently, but not too differently.
Right. And some argue that logically, a piece of evidence should either strengthen or weaken a hypothesis, not both. And it really gets to the heart of the question, how much variation in expert reasoning is acceptable or even valuable?
That's a fascinating debate. It really highlights the challenge of trying to balance individual expertise with some kind of standardized assessment. And speaking of different ways of thinking, the source material also makes a distinction between diagnostic decision making and clinical reasoning as a whole. What's the key difference there?
Yeah, that's an important point. Diagnostic decision-making is often described as a more convergent process. You're gathering info, trying to narrow it down to the most likely diagnosis.
So it's like solving a puzzle. You're working toward one specific solution.
Exactly. And in terms of assessment, it's pretty straightforward. You can define the right answer and the evidence that supports it, but clinical reasoning is often much more divergent,
Divergent, meaning
meaning there might be multiple good paths you could take, depending on the patient, their preferences, the specific situation. It's more like navigating a complex landscape than solving a puzzle. The source uses the example of taking a patient's history. It's this incredibly intricate dance of verbal and nonverbal cues, and experienced doctors just flow through it, not because there's one right way, but because they know how to adapt and respond.
so it's more about being flexible and responsive than following a rigid script.
Exactly. And that brings us to the idea of situational awareness.
Situational awareness, is that like a pilot in a cockpit constantly monitoring everything and adjusting to changes?
That's a great analogy. It's about constantly assessing what's working and what's not, being sensitive to the patient's cues, and knowing when to shift gears. Good clinical reasoning isn't just about knowing the facts. It's about knowing how to apply them skillfully in a dynamic, messy, real-world environment.
And this view of clinical reasoning as something that's really embedded in the moment, in the specific context, leads to something called situativity theory, right?
You got it. Situativity theory argues that reasoning doesn't just happen in our heads in isolation. It's shaped by the situation, the interactions, everything that's happening in the here and now.
So it's less about what you know and more about how you apply that knowledge in a specific situation.
Right. And this theory introduces some interesting concepts like affordances. Those are the opportunities for action that a situation offers. For example, a patient who's really good at explaining their symptoms, that's an affordance.
Okay, makes sense. And then there are effectivities, right?
Yes. Effectivities are the doctor's skills and abilities to act on those affordances. Like, can they ask the right questions to get the information they need from that articulate patient?
So it's this constant back and forth, this interplay between what the situation offers and what the doctor can do with it.
Exactly. And if you really want to assess clinical reasoning from this perspective, you need to actually observe doctors in action. You need to see if they're adapting, responding appropriately, making good judgments in the moment.
So direct observation is key, which brings us to another interesting point the source material brings up. The return of human judgment in assessment. Sound like for a while there, we were trying to move away from that to make things more objective.
Yeah, for a long time, there was a big push for objectivity and standardization in assessment. The thinking was, get rid of human bias, make everything quantifiable.
But now it seems like the pendulum is swinging back the other way. There's a recognition that human judgment is actually essential for assessing complex skills like clinical reasoning.
Absolutely. We're realizing that you can't just reduce everything to numbers and checklists.
Yeah.
There's a nuance to expert judgment, a depth of understanding that's really valuable in assessing something as intricate as clinical reasoning.
But I imagine it's not just a return to the old school way of doing things. It's not just about throwing someone in a clinic and saying, okay, go see patients, we'll be watching.
Definitely not. We've learned a lot about the potential pitfalls of purely subjective assessment. We know that we need to observe doctors across a range of situations, be aware of our own biases, and be systematic in how we gather and interpret information. And there's a lot of really exciting research going on right now, trying to understand how experts actually make judgments about reasoning and error in others.
And how does script theory fit into this renewed focus on human judgment?
Well, now researchers are applying script theory to the assessors themselves. The idea is that assessors also develop their own assessment scripts based on their experience and what they consider to be good clinical reasoning. And there's a lot of interest in getting multiple perspectives on the same case, moving away from the idea that there's one single correct way to judge someone's reasoning.
Makes sense. Different experts might pick up on different things, see the same situation through different lenses.
Exactly. And there's also some really fascinating research going on about the role of narrative in assessment.
Narrative, like storytelling.
Yeah. The stories that assessors tell themselves about a doctor's reasoning and the stories that doctors tell to explain their thinking, they can really influence the final judgment. And another cool area of research is looking at context specificity.
Okay, context specificity, what's that all about?
It's basically asking, why might a doctor make different decisions for patients with seemingly identical symptoms? What are the unique factors in each situation that might lead to different approaches? And this is all about understanding the interplay of those affordances and effectivities we talked about earlier.
So taking a more holistic view, not just looking at symptoms in isolation.
Exactly. And ultimately, this research is all about improving how we teach and assess clinical reasoning, making sure that doctors are equipped to make the best possible decisions for their patients.
Wow. So we've come a long way from those early PMP simulations. It's been a pretty amazing journey.
It really have. We've gone from this very linear, objective view of clinical reasoning to something much more complex, nuanced, and situated in the real world.
And recognizing that human judgment, while it has its challenges, is absolutely crucial to assessing something as multifaceted as clinical reasoning.
Absolutely. And it
Wow.
makes you think, right? How are the doctors you interact with being assessed? Are we truly capturing their ability to think critically, adapt to unique situations, and make the best possible decisions for their patients?
It's a great point. And for all of us deep divers out there, I think this really highlights that getting a diagnosis or a treatment plan, it's not just a simple input-output process. It's about understanding the thinking, the reasoning, the human element that goes into every decision.
Couldn't have said it better myself. It's a reminder that good healthcare is as much about the how as it is about the what.
Food for thought. Thanks for joining us for this deep dive. Until next time, keep those minds curious.
Keep diving deeper, folks.